Hello and welcome to the University at Albany Center for Public Health Grand Round Series. I'm Peter Slocum and I'll be your moderator today. Before we begin, we'd like to remind you to please take a moment after the broadcast to fill out your evaluation. Your feedback is very helpful in the development of future programs. I'd also like to remind you that we'll be taking your questions later in the hour. The toll-free number is 1-800-452-0662. You may also send your questions by fax to 518-426-0696. Our topic today is Building the 21st Century Local Health Department with Dr. Michael Caldwell, the current president of the National Association of County and City Health Officials, as well as the commissioner of the Dutchess County Health Department here in New York State. Thank you for joining us, Dr. Caldwell.
Good morning, Peter. It's great to be here.
So we'd like to start talking a little bit about the project that we've all been spending so much time with, and that's the preparedness, the bioterrorism preparedness in the wake of the terrorism attacks. But before we get into that, you preface our discussion a little bit with a little bit about the history of public health in the United States, how it developed to where we are today.
Well, that's right, Peter. I wanted to talk a little bit about the history of public health and why we are where we are today. And if we could go to my first slide, Public Health in the 20th Century, I wanted to talk about the implementation of scientific knowledge and learning into practice. This occurred primarily in the 19th century, where we had for the first time the germ theory, which was proven, and we also were able to find ways of controlling germs, thereby controlling disease. This was the era of the invention of public health laws, as well as enforcement of those laws. And as you see on the slide, you see evidence of environmental sanitation, either through promoting inspection of our milk supply or promotion of preventing disease through keeping our sewage separate from our water supply. It was also a time where we recognized how we could separate people and quarantine them in a way to be able to reduce the spread of communicable diseases. And we were also able to identify new methods of preventing disease through vaccination. And that was quite exciting, and that was done not only for viruses but bacteria as well. So this great era, the late 19th and early 20th century, was an era where we really had the fundamental foundations of public health, which still exist today. Right. We've done such a good job with them, though, that people often forget that we do things day in and day out to keep things as healthy as they should be.
And of course, as our audience of public health people knows well, the major increases in the reduction in mortality and morbidity in our society have come from those very steps you just talked about.
Well, that's right, because during that time, in the late 19th and early 20th century, the major killers of us Americans were primarily communicable diseases and germs and bacterias and viruses. Right. But now, thankfully, we have other problems to work on.
Let's talk a little bit about then how the focus of public health has changed over time.
Well, in the 20th century, there were new challenges that emerged because of our success with communicable disease control. And you could see that the causes of death shifted from communicable diseases to heart disease, cancer, stroke, and lung disease. And we started to get more of an emphasis on chronic diseases. Local public health departments also are becoming more focused on public health education. So it was less of a time of us developing new public health laws and enforcing those laws, rather than taking new scientific knowledge for these chronic diseases and trying to communicate that to doctors and the community so that they could take control through their own responsibilities of reducing the risk factors for these chronic diseases. And we know them very well, Peter. You're supposed to not smoke. Right. You're supposed to eat a balanced diet. You're supposed to get exercise. You're supposed to do some preventive screenings. You're supposed to know your cholesterol level, know your blood pressure level, and these types of things. So we spent a lot of time toward the second half of the 20th century, working on this. And local public health departments, state public health departments were the conveners and leaders in their community to communicate a lot of this information.
Right. And there was a need in that process to redefine public health.
Well, yes, because as you noted in the beginning of the 20th century, it was kind of easy for us, and there was more of an acceptance in America to say, well, this is the law, we're creating these laws, and we're going to tell you what to do, and you're going to do it. And people, for the most part, did it. There were a few people that didn't, but we put them in jail, and there was less of an emphasis on civil liberties. So now it's more complex, and we recognized in public health that we needed to have a common set of language, a common set of resources that we could all understand and relate to. And that's why you see here some of the new resources that have been developed and have been withstanding the test of time over the last 20 years. The core functions of public health, the 10 essential public health services, the Healthy People 2000 and 2010 and soon 2020. And at NACCHO, the National Association of County and City Health Officials, we got tired of hearing the idea, the concept that when you've seen one local public health department, you've seen one local health department, because there was no consistency between what one did and one another. The era of that is over right now, and we are now really believe that we must guarantee to anyone in America that there is some general sense of what they can expect from their local health department. There needs to be consistency. And developing this common language and common resources is a really major step in that direction. NACCHO will be unveiling its first draft of what operational definition of a local public health department is at our national meeting, which we want everybody to try to make. It's in Boston, July 12th through 16th, and you can get more information on our website, www.naccho.org.
Yeah, which we'll show later, I think on a later slide. What were some of the new challenges that public health that we all face that led to this kind of work that you're engaged in now?
Well, clearly, as we're going through the process of building these common sets of resources, new threats have come about. Certainly West Nile virus back in 1999 first emerged in New York. In 2001, of course, the terrorist attacks, and then the still unexplained anthrax attacks. We also have dealt with E. coli outbreaks, monkeypox, SARS, reemergence of plague in certain areas, now recently Marburg and Ebola viruses, the avian flu threat, the multi-year flu vaccine crisis, because it really just wasn't last year. Rabies is a continuing problem. All of these new threats are emerging at the same time that we're trying to maintain the foundation and fundamentals of public health. So we're really building upon these foundations, and we're really not replacing anything that we have done, because we can't. Because if we start dismantling our core foundation of what we started in the earlier 20th century, then we're going to have more problems.
Well, I know that means some interesting funding challenges, which also funding always has a dramatic impact on the capacity that you can build to conduct these operations. Talk a little bit with you about the challenges that local public health offices are facing on the funding side.
Well, we have a pie graph that shows what funding local public health departments get. Now, this was a survey done by NACCHO, and you could see that the federal contribution in dollars is very small. A lot of local public health departments really are funded by state and local dollars, and there is a service component, and that is for, let's say, permits or maybe some nursing care services that you get reimbursed for. The other section could be some fines that local public health department may generate, or other grants. But although the federal contribution in dollars is small, they really are the linchpin to make it all work. The leadership of the CDC and the other federal health agencies is critical to the success of state and local public health departments. It's where there is the basic scientific research and the experts that we rely on all across the country that every local and state health department just cannot have. And they have the leadership there. When you think of every time the CDC comes out with a recommendation, the state and local health departments pretty much take that as gospel, and we usually implement it. Now, we don't, not always. We do sometimes disagree with the CDC, and I know for certain with the smallpox vaccination program, there was a lot of concern about how that should proceed. So we don't just automatically and reflexively follow the CDC, but we certainly value them and understand that without them, we could not do anything at the local level.
Right. Now, since the terrorist attack and the new awareness of threats involving public health, there's been a pretty dramatic increase in federal funding, right?
There has been, and you could see here on the next graph that before 2001, we've been talking about bioterrorism at NACCHO and across the country since about 1998, and we were hopeful to get about $40 million in funding, and you could see before 2001 we had about that much. Suddenly, September 11th hits, there was already existing the Public Health Threats and Emergencies Act, and that was then appropriately funded up to $1 billion. And this money has gone to good use. It has gone to state public health departments. It has gone to local public health departments. And it needs to be sustained. It probably needs to go up to about $2 billion a year if we're really able to protect our community and prepare and plan the way I think we'd all feel comfortable with. But right now we are concerned that there might be some reductions now.
I was going to say, you're not currently too optimistic about moving toward that $2 billion figure.
Well, if we look at the next graph, you'll see that it is disappointing that the 2006 President's budget in draft demonstrates a reduction in this bioterrorism preparedness funding. And as well, we're seeing a reduction, a complete zeroing out of something called the Preventive Health Services Block Grant, a decrease in the next slide you'll see of $131 million down to zero, which is just really quite disappointing. And we're doing our best to educate our congressional representatives that this really doesn't make sense, and we're really going to see this impacting our ability across the country, in communities all across America, in sustaining the education programs, especially directed at chronic diseases that we need to continue to do so much work on.
Right. This it runs the risk, as I believe you're saying, that of having the bioterrorism activity begin to overwhelm and the funding stream overwhelm the other core activities that deal with chronic disease that are making up the basic function of the public health departments.
Well, that's right, and it could appear as if their government is giving us emergency preparedness funding and taking away preventive health funding. But remember that first pie graph I showed you. Most local public health department funding really doesn't come from the federal government.
Right.
Most comes from the state and local. But that federal money is really important to leverage the state and local money. That leadership gives state and local elected officials the idea that they should also contribute to. So I can tell you that in Dutchess County, New York, we get about $300,000 from this CDC Emergency Preparedness Grant. But the state and as well as our local government does put in more money to it. Now, if that money were to go away, maybe the state and local governments would withdraw their money as well.
I see.
And that's really a concern.
Right. So it's a matter of maintaining the sort of community political will, small p political will.
Absolutely.
Behind that function. And what's the balance then between those different functions? I know you have a graph that talks about the core functions and preparedness, how they relate to each other.
Yes, well, it's been a strongly debated issue now about all of this influx of money coming in from emergency preparedness to state and local public health departments, and there's been a concern about the militarization of local health departments, and are we just undercutting completely our core mission? I believe that the public health preparedness money has been a saving grace for us in many ways. It's giving us resources and accelerating the promise of the 21st century public health department in a way that we could not have been able to get to so quickly.
Okay.
We need to take these new resources, whether it be in technology or in staff, professionals, and integrate them into the other areas of our public health departments. Now, you can't do that right away because you have to figure out what positions do you want, what positions do you need, how does this dovetail into some of this national resources and dialogue that we were talking about, what should a local health department have across the country. And then once you are able to say you've fulfilled your deliverables for your BT grant, then you look at trying to integrate these wonderful resources into other programs.
Okay.
And I think there has been a frustration upon some of the staffs and some of the academic public health departments saying, well, all I see you doing is focusing on emergency preparedness. You haven't integrated into the department. And I'd say just give us a little time. Let us understand what we're doing. Let us be able to prepare for these point of distribution, these pod sites. Let's be able to put in our deliverables and tell our community we're there for you in the crisis, and then we can take a step back and look at these wonderful tools that we have and wonderful professionals and integrate them more in our regular programs. But we have to keep that in mind, that they must be integrated.
Well, you were talking to me before we went on today about the example of the distribution of vaccine in an emergency and the flu vaccine uncertainties of the last year, and you were able to use the expertise and the staff you gained through the bioterrorism preparedness to help your community deal with that.
Well, that's right. When the flu vaccine crisis shortage, when that hit, what we did is recognize that, well, we kind of got lucky, or unlucky, I should say. Our public health nurse decided this year to order all of our vaccine from Aventis Pasteur. And the problem is everyone else in the community ordered from Chiron. So while we had the vaccine, we also had the burden and responsibility to try to distribute it in a way that was fair. Now, we had enough vaccine to do our normal 20 clinics around Dutchess County. But now, we were not just going to be getting 50 or 200 people per clinic. We were going to get 1,500 people per clinic. And in anticipation of that, we scrapped our initial flu clinic calendar, and we went back to our emergency preparedness planning and looked at our pod sites and said, where can we handle this number of people quickly and safely? And so that really helped us. So by the time we did our 4th or 5th clinic, we used the flu vaccine clinic as a drill to satisfy our bioterrorism emergency preparedness grant deliverable. And so we had a biostatistician and a GIS technician right there. And at the end of each clinic, we were able to produce a map of who came from where in Dutchess County, what zip code they were from, and what vaccine that they got.
Right, so you were able to see what kind of penetration you'd achieved right away, right?
Right away, and it was very important to our elected officials because they wanted to know that our Dutchess County vaccine were going to Dutchess County residents, and I was able to say 97% of the people that came were Dutchess County residents, and the other 3% were just visiting in-laws from Florida.
Right. Speaking of moving between Florida and New York, let's talk about the geographical distribution and differences in local public health departments around the country. You've got you're from New York, and you can give us some perspective on how public health services are delivered here.
Yes. Did the glass half full and half empty show up already? Did that graphic?
No, I think we missed that. You want to go back to that
well,
for a
if
second?
you don't mind,
okay.
I would like to just for 1 second. This was important. This glass to me represents a real important tension in the public health community right now, and that is should this emergency preparedness opportunity for local public health department be seen as a good thing or a bad thing. And I think overall it is a good thing, but we just have to assure that the funding is sustained. We have to assure that other funding for other programs is maintained as well. And overall, I believe that we're going to be a better response to our communities, better local public health departments because of this new influx of resources, not just in dollars, but in professionals and technology. And we have to work to integrate that back into the department. So I'm more of a glass half full rather than glass half empty, but it's still going to take a lot of work.
You mentioned the fact that you have a GIS specialist on staff now who helped you with the flu vaccine distribution that was not there, that person wasn't there before.
No, they weren't there, and of course we dovetail this into other needs into the county with other planning needs. But we have a big problem with Lyme disease in Hudson Valley, and our Congresswoman Sue Kelly and Maurice Hinchey are both concerned about this. And we were able to show them a map of Dutchess County where all the cases of Lyme disease are using that technology. So we are able to use this new technology to help us with other public health problems.
Right. That's how you've done it. How do other health departments around New York work, and what's the difference? You talked about the need to come up with a standard set of criteria for local departments all around the country. We're going to look at a couple of states now and see what some of their differences are.
Yes, and I think this is really an important discussion to have. If you look at the graphic of New York, we're very fortunate in New York that we have about 62 counties, 58 local health departments. New York City is comprised of 5 counties, but the differences in the shaded areas that you see are the difference between what we call full service departments of health and non-full service. The darker orange ones are full service, and what that means is that they have local environmental health services. The lightly colored counties are areas where the State Department of Health oversees the environmental health services. But there is a commitment in New York and an entitlement in the state public health law that guarantees all local public health departments about 1/3 of their funding, which is something that is not replicated all across the country, but is really important that every state have a commitment to a strong state local public health system. And you cannot have that system unless you don't have shared resources. So we feel that in New York State we have a good county-based system. The government of New York State is primarily a county-based system, and the state public health law was then able to reflect that. Right. So we have fairly good number of local health departments for our population of 18 million.
And you have the match or something. Every dollar the county puts up, the state contributes 30%.
About 30 cents or 36 cents.
Right. Okay.
Now that is county dollars in total. We have to reduce our request to the state by anything we get from permit fees or grants, other grants or fines or income generated from our nursing care.
But that gives you an incentive, it gives counties an incentive to put money into public health.
Well,
right?
That's a really important point, Peter, that that entitlement, that state public health law, that guarantee that whatever the county decides is important to maybe start a cardiac arrest surveillance database system or a chronic disease, diabetes educational program, every time the county wants to invest in that, they know every dollar they put down, they're going to get a little money back from the state. And it makes it more appealing to local communities to be able to think creatively to create programs.
Right. There still can be, I guess, something of a hardship on the poorest of counties, which don't have enough tax levy to come up to even get those programs on the board.
Well, that's right, but just think of the way it would be if that entitlement and contribution by the state was taken away immediately.
Right.
And I'm happy to say that in New York State, the county health officials have a really tight organization. We meet monthly, and I encourage all my colleagues across the country to develop their own state association of county health officials just so they can get together, share ideas, and also defend against possible cuts to resources, and this happened in New York State. The executive budget that was proposed sought to eliminate that entitlement. So we organized and talked to our elected representatives in the Senate and the Assembly and said, yeah, this makes no sense.
Right.
You know, this is important. We need this guarantee in order to protect our community, and thankfully that was reinstituted.
Restored, okay. Can we take a look at a couple of other states and how they
Sure.
organize?
Well, I am very knowledgeable now about the state of Nebraska because my colleague, who is the president of the state health officials organization, Dick Raymond, is from Nebraska. And if you look at the state of Nebraska, and each one of those boxes is a county. Now, the shaded ones there are the ones where there were local health departments before 2001. And now, after 2001, you could see there's nowhere in Nebraska that's not covered by a local Department of Health. They have really successfully been able to regionalize local health departments. Now, Nebraska has about 1.7 million people, and it's very rural compared to New York even. But there are some populated areas, more so on the eastern part of Nebraska. But they very thoughtfully decided that they needed a strong state, local public health system that had not previously existed. And they used the opportunity of September 11th to say this was necessary to protect our citizens. And they also decided very ingeniously, I think, use some of the tobacco control money from the Attorney General settlement to be able to help fund this initially. Now, you know, across the country, a lot of this tobacco money went to other uses like building golf courses or paving roads. Well, in the state of Nebraska, they did something really, really profound with it, and I think our country is going to be better served by looking at that model because there are a few other states that could learn from Nebraska's example.
That's right. It hasn't always been easy for the states, the health officials, to keep that tobacco money in the public health stream where it really belonged, was intended to go.
Absolutely.
Let's look now at Massachusetts, another more densely populated state and with an interesting governance structure of its own.
Yes, well, Massachusetts has approximately 5 to 6 million people, and if you see all those little dots there, that is because Massachusetts has more local public health departments than any state in the union. They have 353 local health departments for only 5 million people, and you wonder, how did that happen? Well, in Massachusetts, they have counties, but they're essentially just lines on a map. They're really a traditional New England-based, town-based system. So every town wants to have its own local health department. But what they've realized now is that after emergency preparedness, that they cannot function completely to protect their communities without working more in a coordinated fashion. So there is a lot of effort underway now to figure out how can the people in Massachusetts be better served by having some type of regionalization. And they're using the initial discussion of bioterrorism and emergency preparedness to then, I believe, think about other ways that they can be more successful in regionalizing some of their work, such as with communicable diseases or chronic diseases. So I think this early discussion now in Massachusetts is going to be very fruitful.
So they'll be able to share resources for epidemiology or other things, working with, let's say, Lyme disease, another state that's affected by Lyme disease, then across the town lines more effectively, right?
Well, you would hope so, because you can't have 353 epidemiologists in the state of Massachusetts. They know that. But yet there needs to be more thought between the state and local public health system and how it can work better. But a lot of this, once again, goes back to the way the governments are set up, the way the state and the local governments are set up, the way the state public health law has decided to create local health departments. So I think as Massachusetts moves forward, you're going to see more creativity, which was catalyzed by the need to be creative to respond to the events of September 11th.
Right.
I mean, to run a public health education program, you don't necessarily need to have this impending sense that you must cooperate with your neighbor. You could do your own health education program your way. But now when you realize I'm going to have to set up a distribution site to hand out antibiotics to thousands of people, I can't do this town by town. I have to be more thoughtful on how to do that. So those relationships that are developing now around that issue are going to, I think, be reflected in other public health issues. So over the next 5 to 10 years, I think you're going to see some more real courage in how Massachusetts deals with this issue of regionalizing their local health departments. You can imagine if you're in a town in Massachusetts, you have a great pride in your town and you almost don't want to work with the town next door because you think you can do it better. But the emergency preparedness and BT process is breaking down those barriers, saying we have to be more thoughtful than that.
That's part of the new world we all face. Right?
That's right.
I want to take just a break for a second and let the audience know we'll be taking your questions in a few minutes. The toll-free number is 800-452-0662, and you can also fax in questions to us at 518-426-0696. Now, I want to ask you to explain this term full use that I've seen before. Can you, we have a slide about it, and can you tell us what that means?
Yes. Well, this has been a term that has come about to replace what many of you may remember. We were saying early on, dual use. We will take this emergency preparedness money and not only use it for emergency preparedness, we'll use it for other things in our department too. And unfortunately, some of our congressional representatives were cynical about that word of dual use and saying, well, what do you mean, Dr. Caldwell? You're gonna take this money for bioterrorism and you're not gonna use it for bioterrorism, you're gonna use it on something else? And we said, no, you don't understand. So we said, well, let's scrap that term dual use and let's say we're gonna make full use of these funds.
Okay.
We're going to use them for emergency preparedness and bioterrorism, but not only that, those resources, those assets we develop are going to be extended throughout our Department of Health and help all that we do so that we will be able to better respond to a flu vaccine shortage crisis, that we'll be better able to detect more quickly an outbreak of E. coli or SARS and have better communications with our hospitals and medical providers so that we'll be able to detect a problem, be able to isolate it and manage it and get rid of the problem very quickly. We'll be able to communicate better with our state health departments and the CDC. So if we see something in one part of the country, they'll maybe be able to pull together other simultaneous problems, whether it be a communicable disease or terrorist attack in other places more quickly. So we're going to make full use of these new resources, but we need to assure that the resources are maintained, otherwise we will not be able to integrate them into the rest of our department. If you could put the slide up again, you'll see some of the tangible benefits have been seen with the flu vaccine shortage, and probably more important than anything else, planning. We have often had public health laws that we enforced and we just did. We did our work, we did our inspections, but we were not as able to be able to step back, think, and plan on how to improve our communication with our community. We've developed better technology through telephone hotlines and even GIS mapping. Community health alert networks are really being developed across our country. We're doing better syndromic surveillance with our hospitals and the medical providers, and we're recruiting volunteers in medical reserve corps throughout the country, which are not only helping in case we have to distribute medicines to after a bioterrorism attack, but whether we had, once again, this flu vaccine shortage crisis, we needed to call those same people up to help us out. ICS stands for Incident Command Service Training, and this is, once again, something we have learned to do a better job of. We are becoming the health department emergency operations center. All local health departments now have to understand they have the responsibility and role in their community, whether we want it or not, to be the health emergency operations center for our communities. And I can tell you one story in Dutchess County. We had a hoax of anthrax in our probation department. Now, the hoax was phoned in over the President's Day weekend in 2004 to 100 different voicemails to the probation officers. Now, somebody called in and heard one, and then we realized there were 100 of them. So I was sitting in the Emergency Operations Center with our county executive, the sheriff, the FBI, and the local emergency response team. And they all looked at me, the Commissioner of Health, and said, well, Dr. Caldwell, you know, this is, you're the commander-in-chief here. You're the one who's got to tell us what to do. Right. And I said, well, I don't have an anthrax meter to be able to walk around and figure out whether there really is anthrax there or not. So we went back to looking at whether this was a threat or not a threat. And I said, can't you just handle this like a bomb threat? You know, you don't call me for that. Like, well, this is different. This is a BT threat. So not only do we have to be available and responsible to deal with actual a white powder that we see or a letter that says I'm going to cause problem, we have to be there side by side with our colleagues in the fire, police, EMS, sheriff, and FBI in an ongoing way that we never were before.
Right, and that relates to the issue of planning that you spoke about before. Not only are you in the hot seat as the commander in an incident like that because of its public health implications, but you don't want to be meeting the sheriff and the county executive and the other emergency preparedness people for the first time. Your relationship needs to be a strong one when you get to that point of a crisis where you have to deal together with it.
Yeah, and I've often said that you don't want to be exchanging business cards of introduction in the Emergency Operations Center. So partnerships are so important, and we are developing newer partnerships through emergency preparedness that are benefiting us in our other day-to-day core activities. I tell you, Peter, now, I never thought I'd be a member of the Chiefs of Police of Dutchess County, but now I'm a card-carrying member of the Chiefs of Police of Dutchess County. That's because I was invited in to be their network, and of course we invite them to be a part of our emergency preparedness and bioterrorism planning. So bioterrorism planning, they're kind of moving away from this now and trying to let everyone realize it's an all hazards planning. We need to be prepared for anything. And if we could prepare for a bioterrorist event, we could be able to handle just about anything.
Exactly.
And that's why we need to be under the umbrella of our own emergency response, emergency operations system. We'll have that expertise to open up clinics, to give out medicines if we need to. We'll be there for technical assistance and expertise if there's anything health related. But I am finding we have so much more work to do with partnerships. Only this year now, we're in the 4th year of our grant, we're focusing our attention on special needs populations. The first couple of years we were just trying to figure out what did we need to do as a health department, what resources do we need, what staff do we need, how do we recruit these people, how do we train them. And now we've gotten those initial partnerships built. Now we're looking at who have we not talked to. Mental health community, very important to have them be a strong core component of everything that we do. Because I bet you most people would say we would probably the one thing we needed more than anything on September 11th was mental health, and we still need that. What about our vulnerable populations in the nursing home or assisted living? They're not going to come to a pod site. They're not going to empty the nursing home and bring them to a point of distribution site. We have to be thoughtful and work with our nursing homes, say, listen, we'll give you the medicines, but we need you to be trained and know what to do at your nursing home. What about schools? What about developmentally disabled children? It is a real awesome responsibility, but we can't do it alone in public health. We need to be able to work together with our other colleagues in the community, not only the governmental colleagues, but the business community as well.
And your homebound elderly, your home care programs, I know many counties run, there's another huge population that needs special attention in a crisis like this.
That's right, and you have to be thoughtful about thinking of all of these populations, and you also have to make sure that they are engaged. You have to have a plan to be able to make sure that these populations are taken care of, because when a crisis happens, people are going to always say, listen, you had 4 or 5 years to think of all these things. Why haven't you done it yet?
Right.
And we can't be complaining, saying, oh, well, our resources got cut. That's just not going to carry the day during a crisis. We have to think of these things and advocate to our elected officials that we're not doing everything we need to be doing as fast as we should be doing it, as fast as the community expects us to. And when there's a problem, that's going to become evident, and we don't want that to happen.
There's certainly a level of public expectation about our society's, our government's ability to respond to these things that did not exist prior to 9/11, and it's a justified expectation, it seems to me.
And that's an important point, Peter. I think that for the first time, public health officials around the country understand that the public expects them to be there in a crisis. They expect them to show some leadership. They expect them to more than anything else they do, they expect that to be a core function. And I think it's taken some time and is still not fully saturated in all of our staff across the country, that is something that we have to have an expertise in, just like it is in environmental and nursing and communicable disease control. We have to have emergency public health preparedness planning as a core responsibility.
Well, that's a perfect lead into our next slide, but just given everything you've said, what will it take to build an effective 21st century health department at the local level?
Well, if we look at this slide, you'll see I've come up with some ingredients that I think are key. And once again, this is not to replace everything that we've done up to now, but it is building it upon that system and then integrating it throughout. But the real focus on planning, making that a core part of every local public health department, that you have thoughtful planning based upon the review of data in the community, the understanding of where there are gaps in data, and to assure that you try to fill those gaps, because you cannot plan effectively without having good, reliable data, whether it comes from the CDC, the state, or your local community. You need to do a better job of coordinating, and a lot of this improvements in coordination as well as communication have really been the result of our resources we've gotten from emergency preparedness planning. We can do a better job with everything we do at the health department by better coordinating and better communicating within our departments and within the community. And one of the issues with communication I want to remind all of my colleagues about is that we need to communicate to our staffs about the value of strategic planning, and to strategically plan with our staffs the priorities for every year, and to make sure our staffs understand this common language that we were talking about, the core functions, the 10 essential services, the operational definition of a health department. We, as the leaders of our agencies, are just starting to get comfortable with that now. But so many of our staffs that are just doing their programmatic duties, that are doing the water supplies, doing the food inspections, doing the immunizations, they have no idea what core functions or 10 essential services are. So you really have to work hard and try your best to make sure that you have a process in your department where there is ongoing communication and education about some of these national public health issues and dialogue, because it will be more meaningful for your staff. They will understand it more, and when you're trying to make changes in your agency, it will be much easier to be able to work with your staff who actually have some understanding of where you're getting your ideas from. Because sometimes I think that the staff at Dutchess County, they see me going off in a direction sometimes, and they can't quite understand why I am going in that direction. And I have to take a step back and say, I have to take the time to be able to review this and make sure they understand. Even if they don't agree with it, at least they understand it. That I'm not just coming out with these concepts on my own. I'm really trying to work with a federal and state dialogue, and I'm trying to integrate this evolving 21st century health department in a very deliberate way. If we could go back to the slide, I want to review the final few concepts, which is integration. And this is key. Integrate these wonderful resources we're getting from emergency preparedness, planning, the coordination, the communication, the professional positions, the technology, integrate it into the rest of the department and whatever works best for you. Developing resources is something very important for the 21st century health department. And that is not just monetary resources, but workforce development. Who are the types of people we need in the departments of health and the state health department and local health department that we don't have now? Who is there in your departments now that's retiring soon, and we need another pool of people coming in? There's a great shortage of public health nurses in this country, and we need to work to help develop and fill that gap, because otherwise we're going to be short on dependable professionals that we have always needed. Finally, the concept of leadership, and this is why I've bolded this here. Everything else that we do is meaningless if there's not leadership in your community at the public health department. And it needs to be visible leadership. Leadership that the community understands that there's a local health department in your town. Now, they want to know, your community wants to know that they can rely on your health department. And they need to know that there is an ongoing dialogue. Right. Now, this is easier for some of my colleagues rather than others, depending upon political constraints. But the more that we can do to tell our story, to say that the fact that you have a normal day when you get up in the morning and you brush your teeth and have your breakfast and bring your children to daycare and go to work and come home and it was just a normal, boring day, those days don't happen by accident. Those days only happen because there's an ongoing network, a public health system that integrates federal, state, and local public health professionals, assuring that the water is safe, that there are no toxins in the water, that they're fluoridated, that the sewage system is properly maintained, that the food supply is safe.
That's right. Nobody thinks about the fact that your department inspects every restaurant every year, but they have an expectation that there's not going to be any problem there in terms of the food supply.
That's right. And as you know, we can't prevent everything, so people have to also use their own common sense and vigilance if they see something. They are our eyes and ears for us, and we're there for them. We need to be responsive. We need to make it easier for them to communicate to us if they see something in the community, and then to appropriately respond back, because that way we can better serve our communities. But leadership is something that each one of us needs to feel comfortable with and demonstrate to our communities.
Right. I'd like to let folks out there know that we're ready to take your calls now. The toll-free number is 800-452-0662, or you may send your written questions by fax, as some of you already have. I've got a pile here, to 518-426-0696. Before we turn to questions, let's just ask you to gaze into your crystal ball for a second and say what your sense of the future of public health is in the United States.
Well, overall, I think it'll probably be more of the same. We're going to see continued intermittent crises. We're going to see funding trying to solve those crises, sort of chasing yesterday's crisis. We're going to need to be able to take these resources in, knowing that they probably will go down again. We'll then have vulnerabilities which will creep up again. And once again, there'll be another crisis, and then there'll be a blame, and then more money. So I think it's this circle that we just have to get used to. And those of us who have been in public health for more than a decade or so know that it is a pretty predictable pattern. Unfortunately, it seems that we've been making a lot of circles recently with some of these issues like West Nile virus and now anthrax and SARS. But I'm very hopeful. I think we're better than we've ever been. We're more professionalized than we've ever been. We're more organized than we've ever been. And if those of you who are watching today are local health departments, make sure you're a member of NACCHO, and if not, please make sure you are, because we really want you. We can only be successful if we all are communicating together. If you don't have a state association of county and city health officials, make sure you try to form that as well. But I could tell you the progress we've made in the last 5 years has just been phenomenal.
Here's if I can interrupt, here's a question that goes right to your point here from New Jersey. For local public health agencies interested in working regionally or building new local public health structures, the way Nebraska has and Massachusetts is working on, where does the leadership have to come from? Does it come from the CDC or the state or local elected officials?
Ultimately, I think it's got to come from the local communities, and if you're using the example of New Jersey, the local communities and the state. I think you will find that there are going to be support with the national organizations and NACCHO, ASTO for the state health officials, as well as the CDC. But and they can provide some incentives and some models to get you there. But ultimately, it's going to be the own community and the own state being able to come up with their own answers, because all of this boils down to state public health laws, and there is really nothing more that can be done outside of the state public health laws, because whatever the state feels is best for itself to structure the state public health system, which is not just the state health department but the local health department, and that's what's going to happen. Nobody from the federal government or anyone else is going to say anything different, but we're going to try to say, hey, this model seems to work well, or this model doesn't seem to work well, and you have this kind of model, and we can give you ideas of how to move forward. But it's really the people in those local communities that are going to make it happen. It was Nebraska that said, we're going to take this tobacco money and make this happen. It was Nebraska that said, we are not happy with this public health system anymore. We need to go in this direction. So while we were all cheering around the country saying, that's great, and you can get pat on the back, it's really the people of that particular state and community that are going to make it happen.
Right. Well, another questioner asked the similar point. You're not advocating then one system for all, that there is one ideal system for each state to adopt. It has to be locally determined depending on local conditions.
Right, primarily state-based, with the state's view of the local dynamics, because every state has its own state constitution, every state has its own state public health laws, and that's where you are able to make changes to assure the existence of state and local health departments, because they don't exist without a state law, and as well as the funding. And I'm so pleased that New York can stand up as a model in the country to be able to demonstrate what we feel is a great partnership in having state and local health departments existing across the country, number one, and number two, having a guaranteed sharing of funding.
Okay, there's another New Jersey question that may reflect the fact that there is sort of a unique kind of local government structure in New Jersey, but asking about the crossing of political boundaries that health issues do, and the states are working together. Can the local units within a state work more effectively together? That would have to come from local leadership, I assume.
Right, and I grew up in New Jersey, so I know New Jersey. I grew up in Leonia, New Jersey, so I grew up in Bergen County, and I know that there's a Bergen County health department, and then each town, for the most part, has its own health department. And I've heard that being from the county health department in New Jersey, sometimes doing public health is like reading a Chinese menu. They do 2 from column A and 1 from column B. So maybe in one town they'll do food service inspection, and in another town they won't do food service inspection. In one town they'll do water supply, and in another town they won't. So I think it's a real great challenge when you have sort of multiple jurisdictions already doing things, as opposed to Nebraska where there was nothing.
Right.
In some ways, it was almost easier to create something from nothing, rather than now having a county structure, town structures, and then each of the towns are chartered with the state.
Right.
And but once again, if you look at Massachusetts, you'll see that emergency preparedness was the catalyst to a deeper conversation about how to do things better, because we have to do things better in a crisis. We have no excuse not to do things better for a point of distribution site, for these pod sites. Now, I'm hoping more and more we'll use those lessons as examples of how we can integrate and move our other public health issues into that same conversation. But I think it's going to take time, but we have to be thoughtful that this could be the opening to solving some of these very difficult issues of improving efficiencies in public health.
Right. All right. One more question. This one from Western New York, saying many local health departments, such as those in rural areas of New York, are predominantly rural and have many fewer resources than the bigger counties do. How do those counties with personnel shortages adequately prepare for future public health emergencies?
Well, a number of my colleagues in Western New York are forming alliances on their own. The State Department of Health didn't say to them, you know, you counties, you get together. They are, because of their own understanding of how their populations move and how they get along together, are forming cooperative arrangements with each other. And this is not just for emergency preparedness planning. They're working together to get grants for maybe chronic diseases, a healthy heart grant. You're seeing cooperation between communities that we haven't seen before. I know my experience in the Hudson Valley, I am part of a network of the 7 counties just north of New York City. We call ourselves HEVRON, the Hudson Valley Regional Health Officials Network. And so we actually have an organization. It's semi-formal, and we meet quarterly, and we talk about a wide range of issues, and we partner together, sometimes with grants, sometimes with emergency preparedness, and sometimes not. So you have to work at this, and you have to keep focusing on how you can work better with your neighbors and get the state to support that. And we've done that with HEVRON. The state does help support our meetings. So it's hard work, as President Bush likes to say, but we're doing it, and we need to be thoughtful in communicating and make sure you don't forget to reach out and know everyone you are supposed to know in your community. Like you said, you should know the superintendents, know the CEOs of the hospitals. Now, this list can get quite cumbersome, so you have to sometimes reach deep down into your organization to use your other professional staff to help you with all of those relationship building activities.
Creating that extensive network in your community and across your lines.
It's so important, because sometimes you get ideas and reflections about issues that you just didn't think of before because you have one perspective, and sometimes that can help you solve a lot of problems that you have been struggling to solve.
Let me direct our attention to the next slide, because it gives our viewers a place to go for more information. If you could, I know you've talked a little bit about NACCHO, but you can fill them in again, perhaps.
Well, there's our website, the www.naccho.org, and for those of you in the know, that is pronounced NACCHO and not Nacho, but whatever makes you remember it, it's double C, and you'll always have access to all of the tools that exist for NACCHO, and you'll be able to be connected to other websites and other resources, such as our colleagues in the state and territorial health officials, as well as the CDC.
Okay. Thank you very much, Dr. Caldwell. This has been a fascinating discussion, and I think probably our audience has gotten a lot out of it. That, unfortunately, is all the time we have for today. Thank you for broadening our perspective on what's going on around the country. And thank you and the audience for tuning in today. We'd like to ask you also to take a few minutes to complete the online evaluation. Your feedback is extraordinarily helpful in developing future programs. This program will be available via web streaming within a week. Please check our website for future details. We'd also like to tell you that we will be rebroadcasting previous programs during the summer months. The first program will be aired on Thursday, June 9, at our new time of 10 a.m. The program we'll be airing is Learning from and Preparing for SARS. I'm Peter Slocum. See you next time on the University at Albany Center for Public Health Preparedness Grand Round Series. Thank you, sir.